I want to talk about human relaxin 2. Now, this is a naturally occurring vasoactive peptide hormone. It mediates cardiovascular changes that accompany, of all things, pregnancy. Serelaxin is a recombinant form of this hormone that has shown promise for the treatment, again, of acute heart failure. So we have another trial. This is the RelaxAHF trial, right, for hospitalized patients with acute heart failure. And although serelaxin reduced cardiovascular deaths, and I'm just reading some of this here, and relieved dyspnea, hospitalizations were not reduced. And did you expect a better result from this?
Yeah, so now we're shifting from chronic heart failure management to acute management in the hospital.
Right,
so
these are guys who are,
these are people who are
in the hospital.
Coming in, and really importantly with this drug, which is called serelaxin, the recombinant form. These are people who are enrolled and treated up front, so within 16 hours of coming to the emergency room. So this is a very interesting drug, as you mentioned. So if you think about what happens in pregnancy, you drop your systemic vascular resistance, you increase your plasma blood volume, all things that happen in heart failure, but you don't have high filling pressures and you don't have pulmonary edema. So why is that? Well, it's because they have all these cardiovascular changes, you increase your renal blood flow, and those are all mediated by this hormone, relaxin. So it makes sense as a potential heart failure therapeutic. So,
and it has built-in safety data.
Yes, you might say that the population is, half the population is exposed to it for 9 months at a time.
Right.
So this trial is very interesting. So first thing I'll say is the primary endpoint of the trial was breathlessness, relief of dyspnea. So it was focused on a symptomatic endpoint, and it was positive. It improved, it was measured by 2 ways. It improved dyspnea in one way, but not the other. There were, in some ways, the most interesting findings from the RELAX trial were not related to their primary endpoint, but other endpoints. The most striking finding was that when you looked out to 180 days, so 6 months after this initial acute treatment, which was only for 48 hours, there was a 35% risk reduction in cardiovascular mortality with serelaxin. Now, there's several caveats. It wasn't the primary endpoint of the trial. It wasn't even a secondary endpoint of the trial. It was really a tertiary endpoint, and it was really in there for safety. So seeing a big treatment effect in that endpoint was very unexpected, and the number of events is still relatively modest. So the other thing that was interesting is that even though we saw this very substantial effect on mortality, we saw no effect on hospitalizations, which is something everybody's
that's what I was trying to get
focused on. So there's this disconnect, which we haven't seen in very many cardiovascular conditions. So I think on the one hand, people were really excited by the results. On the other hand, they were confused by the results. And now there's a much larger trial, RELAX-2, that's ongoing right now with cardiovascular mortality at 6 months as the primary endpoint. So
you know what it reminds me of? Reminds me of what we used to say about DIG. Makes you feel better, right? You can go about the activities of daily life much better, but it doesn't impact length of your life or recurring hospital.
Well, in this case, actually, there was a tantalizing suggestion of a reduction in mortality. In terms of rehospitalization, there wasn't an effect. And rehospitalization is a very challenging endpoint in some ways because there are a lot of factors beyond cardiovascular mechanisms that lead to rehospitalization for heart failure. Some of them are the consequences of treatment, worsening renal function. Others are purely social. If you look at the preventable causes of rehospitalization, they're not uniformly cardiac. So a drug for acutely decompensated heart failure may or may not necessarily have as direct an effect on rehospitalization as we might hope.
So that brings up this whole question.